years ago. And I really like this, a GE junction around 35 centimeter. And we can see here, this is a new texture enhancement mode in addition to this MBI mode. So I really like it. So we can do quickly the exam. And I noticed too that this patient has a little bit on the pylorus is also tight. But I'm really impressed with this type of imaging. You can see the villi nicely. You can see the pylorus. It's really beautiful, honestly. So I feel like it's a good progress for this scope. So how I plan to do the foam, we do 10 centimeter above GE junction for typical type 2. I do short myotomy for type 1, long myotomy based in manometry results for type 3. So you can see here that's the GE junction. We're at 35 centimeter. I'll go anterior approach. All of this area is still tight. We're going to have a hard time with this tunnel when we go down. So around 25 will be around here. I go around 2 to 3 o'clock. So now we're going to start injection around 3 o'clock, needle out. So I noticed one of the things that people do when they inject is that they inject too much. I like just to inject a little bit. Let's just start injecting in the way in. Yeah, inject. Inject. Yeah. Inject. Yeah, that's good. Don't inject more. Needle back. So if you inject way too much, it will spread everywhere, and then you don't have the bubble, and you cannot create a nice entry point. Also, we are going to use bipolar knife. We have Dr. Alghamdi here, Sarah, and she can tell you a little bit more about the bipolar knife.
So the bipolar knife is a combination of bipolar and RFA, and it allows you to cut,
Can you please
dissect,
speak up? We
coagulate
cannot
all
hear
in
you in
one.
here. Can you raise your
So
voice?
we recently did a study, and I saw Mohan, Dr. Ramchadani, he's part of the audience, and him and I and our partner did a study comparing an older version of this knife to the standard monopolar. It was a feasibility study to show that bipolar can really cut. So what we're doing here right now is we're going to start the initial incision. I can see there is a blood vessel here a little bit. And I would like you to be ready to inject too, because this knife we're going to be dissecting and injecting. Before we start with, let me highlight this knife. This gold blade here is where that's the surface of the knife. That's where you cut. The back one here, this called the protective hole. If you put this against mucosa, you're not going to cut the mucosa. And then on the side, for 2 centimeter, first 2 centimeter, actually to 4 centimeter in this ultra, you can cut and coagulate. Coagulation is done with microwave and cut with bipolar knife. So we're going to start our first cut, first to enter. And now we're creating, let's inject a little bit. Yeah. Let's inject. So we're creating the longitudinal incision. Awesome. Beautiful injection. Keep injecting a little bit more. Yeah. Yes. That's good. So now, as you can see, you are creating the entry point. Now we're trimming the edges.
Can we shift the operator's picture to the other side so that we can see the
Same like
working
any
channel
entry
better?
for foam procedure. You really want to work on the margin, trim the margin to create a submucosal space. When you have a bleeding like this one, you can go to coagulation. You can see the microwave coagulation is not strong. So I know this thing called the speedboat, but it's not really fast. It takes time. So why we're using it? It's because it has less, I would say, side effect, less pain. Patient do well with this knife. I can see in the initial cut, we have a little bit cut in the muscle here. I don't want to force the scope in yet. The reason is I see like a little bit cut in the muscle. So I don't want to force it in.
Dr. Osman, can you hear us?
So I'm using coagulation now. You can see here, she doesn't have a thick submucosa, so that's why you have to be careful at the entry point not to go too deep. And sometimes you use water just to see your entry. And I'm learning now that even in POEM procedure, underwater allow you to enter easier, in particularly in a case like that when I don't have a lot of submucosa. So I'm trying to create the entry point, little bit by little bit, cutting. So I noticed that there's a cut in the muscle up there. So that's why I don't want to go. It's not cut, it's just like a small dip in it. If you try to force your scope in a situation like this, guess what? You can make this tear bigger. So now you have to be careful and utilize underwater and inject here. And this is what I'm doing right now. Like trying to make the space wider. We're almost getting in. And before we get in, we can also inject. Yeah. Inject here. Inject more. Inject more. Awesome. That's good. Great job. So we don't want to force the entry. We're getting there, but we don't want to force it, so it still will. You're not going to get a lot of achalasia unless you're in a large referral center to do more than 4 or 5 cases a week. Maximum 2 or 3 a month would be enough.
Okay, so we were discussing the difference between the speedboat and the other knives, and that it is a little bit bulky. So when we are entering the tunnel, I think there was a little bit of muscle injury.
Yes.
Yes.
I think because I didn't over inject, I should have injected more. Also, in this patient, the submucosal layer, as you can see, is not that thick. I'm used like for submucosa and achalasia to be very thick. In her situation, it was thin. It was like very thin, as you can see. And the same here now are closer to GE junction, have the same problem. So that's, I would call one of the toughest area to work in the tiny area here. Let's inject. So we're going to show now how the bipolar is nice in this situation. So that's a fiber here. And you can switch the knife to any direction you want. And you can try to just dissect a little bit by little bit. So it allows you to have this nice dissection even in tight areas. I see blood vessel here. You can see how the coagulation is very controlled, very minimal.
So the coagulation is on the other side, the gold.
Yeah, the gold part. And now we are close to GE junction, so I'm coagulating the blood vessel. And now we're getting to the very thick part. And coagulate as we go. So here, almost now the GE junction. Let's inject here. She had, when we entered initially, she had 5 centimeter segment that was very thick. Like it was very hard to pass the scope through the first time. So now I'm coagulating with the microwave. Inject here.
Injecting. Yeah, injecting.
So it's a very fine dissection. Wow, no space at all. So try to put some water. And in a situation like this, you just want to be patient. Inject.
Injecting.
This patient
right,
did
that's
not do
enough.
dilation before, right?
And muscle injury. So those we sometimes close as well. We inspect after the. After
What if you
closing
have
the tunnel.
muscle injury at the inlet point? How would you deal with that? Just at the inlet
Muscle
point.
injury in the in-between.
At the incision site.
At the incision site, yes.
Yeah.
Usually we can continue dissecting, and then
Inject.
The myotomy, usually we start about 2 centimeters distal to the incision, just to help with closure. But if the muscle is injured at the incision site, it's usually not a problem. We just close it.
Sarah, I would see like some longitudinal fibers overlapping the transverse and inner circular layer. This
Yes.
make some challenges. What's your comment on this?
Like I think we're almost at the GE junction, and it was very tight initially. There's a very long segment that was tight. So this is why we can see the muscle fibers are overlapping. And we just have to try our best to expand the submucosal space.
Inject.
And you can see he's doing that very carefully.
Yeah, so that's why I slowed down. I slowed down completely in this area. It's almost like any mistake here, you're going to have a mucosal opening. So that's why we're trying not to have that. So I'm trying to, this metal part here that you are seeing, I'm putting it against mucosa to protect it. But in the same time, still, the tip can cut it if I don't.
In case if we do have wrap, as you mentioned, is it better to make wider tunnel or keep the same tunnel without further pressure? How you tackle this? Yes. I feel it's getting much better and wider with this slow movement. Yes. So you are coagulating with the back side of the needle through the mucosa. There's no fear from any injury. Wow. I started to notice the palacidial vessels of the gastric side. So you pass the G junction.
In terms of the technique, except where you will locate your scope. So what reality is, some people get used to one approach and get used to it, and I got trained anterior. I will only use posterior for hilar myotomy, post-hilar myotomy cases. Other than that, I use anterior. For people who are doing palm TAF, if you're going to do palm TAF, then you will have to go anterior approach. Some people in the past said anterior better than posterior, or posterior better for GERD, but no study proving that. So I will tell everyone, use whatever makes you feel comfortable. A lot of people like posterior approach because it's easier in terms of location of the scope.
Do you feel the closure is easier or more difficult with one or the other?
I feel like I'm biased. I feel anterior is easier for me. A lot of people, some of my partners use posterior, they will say posterior is easier. In the esophagus, you can always rotate everything. So right now we are 36, so we're gonna go one more centimeter. All right, now it's like very wide. We got to the end. a very nice tunnel now.
Madami.
37. I'm not going to go beyond 2 centimeter. So now we have the tunnel. We're going to take a picture of it. GE junction is here. This was the tough part. We can see a blood vessel here. Let's show you how the coagulation works in this situation. It's really controlled. There's a new modification of this knife called the notch. And with the notch, you can just put it in the blood vessel and you can really control like the blood vessel because you hold it through the notch. So that's a blood vessel here. And I'm going just in all direction, controlling the bleeding. You can even go here toward the mucosa. It's very controlled. It takes time though. It's not like you'll put it. That's where we dissected. That's where the muscle layer was. As we go, I'll just control all these blood vessels. Come back carefully. Another blood vessel here. Let's, as we go, control it. And let's change the mode a little bit. Let's put some water. Nothing is actively bleeding. This was a very tough area that we had to go through. Yes, that's a very tough. Almost can control the bleeding here too. That's all of the muscle layer. I mean, like what I'm doing now is extra. And we can see that we went all the way down. Here's the GE junction. We can see the injection, and we can see that we went beyond the GE junction, 2 centimeter. Now we're good. The next step would be to do myotomy.
You mean to maintain in the third space, you need to have a volume of cases to start, and this is at least 15 to 20 cases. And when you reach this target, then you could do it independently. To maintain your practice, you need at least 2 cases per month to have 25 cases at least per year.
Botox injection, 2, 3 patient doesn't come back again. I don't know whether they die or they are okay, but I don't know. It was working before.
Dr. Othman, can you hear me?